Hey everyone, it's Dr. K, and we are in week 4. So I'm going to spend the next few minutes talking about pretty much everything to cover for this week for HEENT. So as a reminder, there is no sync session summary due for this week, but I do want to just quickly talk about the assignments due for this week, and that does include 4 chapters of reading. These are super important chapters. So please make sure that you're checking out chapters 11, 12, 13, and 14, and that's your head and neck, the eyes chapter, ears and nose, and then throat and oral cavity. Then other important reminders for this week are your shadow health modules. So you do have cough and HEENT due this week. Your QBank modules, again, 84% or better. Please make sure that you're trying to do the best score as possible because those points really do count. And you have urology, endocrine, eyes, ears, nose, and throat. And then your body system video, of course, which is your HEENT with your focus SOAP note. So we're going to talk a lot about a SOAP note as in week 3, you did a write-up. And then back all the way in week 1, you did your comprehensive interview of the patient. So it's going to be putting a lot of those things together, taking the immersion SOAP note PowerPoint that you had in week 2, taking some of the things from week 1, and then really thinking about that objective assessment that you're working on as well. All of those things in culmination are going to give you a SOAP note. So what we need to discuss first is HEENT and the cranial nerves. So yes, you do need to learn the cranial nerves. I'm sorry to tell you that, but you do need to learn the names and the numbers of the cranial nerves. Why is that important? When you're clinically documenting, you need to make sure that you are identifying the correct area and calling it by the specific name. So there's a really great visual representation here. And a lot of people like this because of how it's represented to help them remember. So thinking about 7 for the face, 2 for the eyes or those optic nerves, thinking about 8 for acoustic, 11 for the shoulders. So you can see all of these in the gentleman that is depicted in your picture, as well as the cranial nerves listed by eyes, ears, nose, throat, and neck. And then in this picture, we have understanding the 12 pairs of cranial nerves and their function. So again, olfactory, oculomotor, trochlear, auditory or vestibular, cochlear, the hypoglossal for tongue movement, accessory, optic, trigeminal, abducens, facial, glossopharyngeal, and your vagus. So really great visuals here to help you understand what the cranial nerves are, what they do. So specifically in week 4, you're going to be using equipment. This is the whole point of getting your skills at immersion prior to performing your video. So you're going to receive your otoscope, your ophthalmoscope, and your tuning fork, as well as your pocket Snellen guide. And so you can see some of those visualizations here for you on your screen. So in terms of the Snellen eye chart, you're going to be using that to help detect the patient's visual acuity. Your tuning fork is going to be used for your Weber, your Rinne test, not necessarily for your whisper test. You can do that basically by whispering to the patient. And then with your ophthalmoscope, you're going to show us how you are doing a safe exam with that when you're looking at that cup to disc ratio, the appearance of the vessels and that red reflex. And your otoscope for safe otoscopic examination. So when you're looking in that inner ear canal at the cone of light and the appearance of the tympanic membrane. With potential differential diagnosis of HEENT, there are many. I could spend an entire hour talking about diagnoses for each body system, but I do have a summary for you here of common presentations of things that we would expect that you might see within that FNP scope. So looking at the eyes, we definitely are going to see conjunctivitis, and there's various causes of conjunctivitis. So if you're thinking about doing your SOAP note based on eyes and conjunctivitis possibly being that final diagnosis, you need to be specific in the form. So ICD-10 codes are linked to specific forms of conditions. So conjunctivitis has bacterial forms, it has viral forms, gonococcal. When we're talking about glaucoma, there's open and closed and the emergent factors that go along with those. Cataracts, periorbital cellulitis. There are foreign bodies in the eye, and those can occur from splinters of wood or fragments of metal not wearing appropriate eye protection. Subconjunctival hemorrhages, or that bloodshot eye from an irritant or an injury. Iritis, chemical burns, blepharitis with the eyelashes, glasions versus hordeolums, corneal abrasions visualized on a Woods lamp examination, keratitis, corneal ulcer, migraines, pterygium, and then contact dermatitis. There is contact dermatitis of the eye as well. Some things that you may encounter when it comes to the ears. So otitis media, meaning the inner ear, otitis externa. It's still inside the ear, but the external auditory canal. Mastoiditis, commonly seen in diabetics and immunocompromised patients with severe infection. Infected piercings, vertigo, hearing loss, cholesteomas, cerumen impactions, foreign bodies in the ear, commonly in children, or hearing aids that get trapped in there with the little pieces, AirPods nowadays, tinnitus, Meniere's disease, tympanic membrane rupture, barotraumas, all within the scope of a primary care setting to continue to see those processes. For the nose, I've listed a few here, such as epistaxis, sinusitis, allergic rhinitis, postnasal drip, trauma to the nose, whether that's external or to the turbinates, a deviated septum, sinonasal cancers, and nasal polyps. With the throat, things that you may see are tonsillitis. Again, that could be streptococcal, it could be viral. Pharyngitis could be streptococcal, it could be bacterial of another etiology, it could be viral, it could even be a sexually transmitted infection based of pharyngitis. Laryngitis, or that hoarse voice with the vocal cords, a peritonsillar abscess, an abscess formation to the tonsils, uvulitis at the uvula, epiglottitis, stridor, croup, tracheomalacia, Epstein-Barr virus, also known as mono. With the mouth and tongue, I have herpes listed here in terms of oral ulcerations, parotitis, salidinitis, sleep apnea, certainly a condition that you're going to see. Dysphagia with difficulty swallowing, gastric reflux may actually stem from the upper airway. Ankyloglossia, dental abscesses, dental caries, dental fractures, gingivitis, oral leukoplakias, glossitis, thrush, lichen planus, and cancers. Those are not a complete list, but some things to get you familiar. And then finally, with face and neck, hypothyroidism, hyperthyroidism, hypoparathyroidism, hyperparathyroidism, head and neck cancers, potential of Bell's palsy, trigeminal neuralgia, lymphedema, Ludwig's angina, and angioedema. So all potential differential diagnoses depending on the body system and the symptoms the patient is presenting with. So I have some great visuals here for you. And this comes from Bates on table 12.1, your red eye differential. So you will see in conjunctivitis different patterns as opposed to other differentials, such as a subconjunctival hemorrhage and what that might look like, a corneal injury or infection, acute iritis, and acute angle closure glaucoma. So again, really great aids in your Bates book. Please make sure that you are doing your reading. Although there are not quizzes associated with your reading content, it's really going to make you better in terms of your clinical practice and your understanding of these processes to prepare you for clinical. So please make sure you are using your Bates as your most formal guide in this course. And then here I just have some pictures pulled from Bates in the difference of a stye or a hordeolum and a chalazion. This is something that board exams, again, loves to ask about. I try and give you those pearls and things that I can remember when studying for boards. But styes or hordeolums, I remember hordeolum as a hordeolum hurts. And so when you're thinking about that, that can be in the upper eyelid, it can be in the lower eyelid, as opposed to a chalazion or a painless area. Then we have the differences between open angle glaucoma and closed angle, and then a great visualization here for you. And then this just gives you a little bit of an idea of those optic pathways from the brain circumstance. So we're looking at the visual cortex all the way at the posterior aspect, the optic chiasm, and then the optic nerves and how those travel and kind of the cross pathways. So when you are performing your video this week, there are obviously things that you're going to need to know as it pertains to the body systems themselves, but we're going to give you a total of 10 points as long as you are doing these professionalism aspects. So number one, you should be having a professional appearance in all of your videos. This should be a point that you're getting, 2 points that you're getting by just showing your video to your professor. You should be in a business casual or professional clothing with no scrubs, wearing your lab coat after attending immersion. You should be performing this autonomously, meaning that you've practiced a lot before finally recording your video. Again, we don't know how many times you are working to practice on these videos before you submit your best attempt to us. So please take advantage of that time by practicing early in the week. You absolutely have to have consent of your patient prior to your instructor being able to grade your video. Again, you are a USU FNP student. You're asking your patient for permission to record the video of their physical examination and upload it to YouTube as unlisted for your instructor to grade. Do you have their permission? When they say yes, you can move on from that step. Communication and flow and positioning also get you 2 points each, and those are just from the continuity of flow, making sure that you are able to verbalize those steps with minimal interruption and without frequent interruption. So when it comes to the head, and we're going directly into our rubric now, we are assessing the hair for distribution and texture, assessing for shape of the head and any trauma, inspecting for rashes or lesions of the scalp, and then palpating for any cysts, lesions, depressions, and hematomas. When it comes to the eyes, you are assessing visual acuity by the Pocket-Snellen chart. So a good way to do that is 6 feet simulation apart, is basically arm to arm, that you are having your arms touch from the patient's arm and meeting in the middle should give you roughly an estimate of 6 feet apart. However, we want to make sure that you're staying in the camera view at all times. So please, when you are setting up your room prior to this video and watching this before submitting your video to the Dropbox, that you are within the video frame at all times. If you are out of the video, you will be asked to resubmit your video, as we will not be able to grade it. So in doing visual acuity, you're going to have the patient cover one eye with their hand and read the lowest line possible. And so they can choose whichever eye. If they do wear corrective lenses, you want to make sure that they are having those on and utilizing them as appropriate. If they don't have those possible or with them, you can go ahead and say that. And then they're going to contralaterally perform that with the opposite eye. And ideally, I always ask the patient to read it backwards so that they don't memorize the same pattern. And then finally, you will do no covering, so a complete unobstructed view with both eyes at their lowest line that they're able to read. And so at 6 feet, that's going to simulate as if the patient was 20 feet away, and that's how you get 20/20 vision, 20/30, and so forth. Visual fields by confrontation. So you're going to test each eye separately and then test together. And so that is performed in that static wiggle test in your book, where you're having the performing NP showing you that they are wiggling their fingers. And so the patient would cover their eye and tell you when it comes into view. So in assessing general inspection of the eye, you're looking for that exophthalmos, hopefully not there, ptosis. You're looking at the eyelids. A great aid there is on page 357. When looking at the conjunctiva and the lacrimal system, so you want to gently pull down on the eyelid while you're looking at those. Evaluating the sclera, the iris, the cornea. Then for cranial nerve 2, you're going to, again, make sure you're mentioning the cranial nerve name as well as the number while you are performing these in order to earn all of the points possible for your rubric. But for pupillary reaction to light directly and consensually, you're using your pen light, and that is cranial nerve 2 or your optic nerve. So looking at the opposite's eye reaction to light, and you would do that while using your pen light, as I mentioned. With extraocular motions, you're going to see this visual here on your right, which is going to show you ocular motor or cranial nerve 3, the trochlear or cranial nerve 4, and your abducens, cranial nerve 6. So 3, 4, and 6 are your extraocular movements of your eyes. You can see cranial nerve 3 is that X or every other direction, whereas trochlear is medial, so inward and downward, and abducens is directly lateral. You're also evaluating at this time for nystagmus, verbalizing while performing extraocular movements. You're looking for that vibration of the eyes. That's something I do have a little pink star next to it that is commonly forgotten to be mentioned and forgotten to be performed. So please pay special attention to that. With convergence, that you're verbalizing and demonstrating this. So page 359, converging in on your pen light, and then accommodation. So changing the shape of the lens, bringing that into focus behind the iris. That may not be seen, but you're going to perform a test that would show it. With the ophthalmoscope exam, you're going to show us correct performance using the ophthalmoscope. So safely being able to perform that, where you're not hitting the patient's face while you're trying to look at their eye. So your left eye and the patient's left eye should be visualized at the same time, whereas the right eye and right eye. And so what you want to make sure of is if you are wearing glasses, you are lining kind of up with the patient. And when you're using your ophthalmoscope, that you're really kind of closing your eye and looking at it, and then opposite when you're doing it. So you want to make sure that you are dimming the lights if possible. Now, again, if you have to leave the camera view to do that, you want to make sure that you would verbalize that you would dim the lights if possible. Safety with the ophthalmoscope, as I mentioned, and that you're verbalizing visualization of the cornea and the lens, that you're looking for that red reflex, and an absence of a red reflex suggesting opacity of a cataract. And then the optic disc cup and the ratio with that, as well as inspection of the vessels. And so again, I have some visualizations there. On the lower part of the screen, you can see that cup ratio. Whereas on the left-hand screen, you can see different issues with the eye, like macular degeneration, cataracts, and what diabetic retinopathy might look like with those cotton wool spots. When it comes to the nose, we're inspecting and palpating the nose. So be sure you are doing both, not just looking at the nose superficially, that you're also palpating the nose and obstructing the nerves to do that. And that's on page 409. You can see a really good idea about the anatomy of the nose, the tip of the nose, as opposed to the vestibule and the bridge of the nose. And then palpating the sinuses. So you can see the frontal sinuses, where those are located, and your maxillary sinuses. When patients come in and they are complaining of sinusitis or they have a sinus infection, you want to make sure you're absolutely palpating over those areas. And that's in figure 1320 on page 410, inspecting the mucosa of the nose and the nasal terminates. And you should do that with an otoscope. So make sure you are changing your otoscope cover and that you're looking into each nair. And then testing for airflow, as I said, again, with occlusion, or you can have the patient occlude one nair on each side and take a breath in. And then testing for the sense of smell on each side. So this is cranial nerve 1 or your olfactory. Common aids in olfactory or smell are often a citrus scent, such as orange or lemon, coffee, a very distinguishable smell, peppermint. So you can choose a smell that is distinguishable to your patient, but what you should have your patient do when testing cranial nerve 1 is close their eyes, and you're going to instruct them to occlude one side of their nose, and you're going to put a scent close to them and ask them to verbalize identification of the smell. Then you would change the smell to something opposite on the other side when you are assessing it. When it comes to the ears, so you're testing a gross hearing of the auditory canal. With acoustic or cranial nerve 8, you can do this by a watch tick. And so that would only work if you have an old analog watch that does still have a second tick, or by whispered voice. And so at that point, you would make sure you're in camera view, step behind the patient, have them occlude one ear by covering it, and then you would be behind the patient and whisper a word to them in a quiet voice, a few steps behind the patient. They would identify that correctly, a few letters, a series of numbers, or a few words. And then again, you would repeat that on the contralateral side. Please be sure that you are doing things bilaterally. It needs to be done bilaterally, as there are findings that will differ on each side. So just because you are performing it once does not mean that you are getting credit for performing it twice. We want to see you visually perform it on both sides and state those findings. With the Weber test, this is using the tuning fork. And so specifically when you are striking the tuning fork, you need to make sure that you are holding it at the base. If you hold it at that U-shaped portion, that's going to stop the vibratory response. So when you are striking your tuning fork, holding it at the base, in order to perform the Weber test correctly, you are placing this at the midline of the forehead, and you're asking the patient, do they hear it louder on either side? And that is what's considered lateralization. If they do hear it louder on one side, that is an abnormal finding. When it comes to the Rinne test, and you can see this on the upper portion of your screen in the middle, this is when you are again holding it at the base, just as you can see, after you have struck the tuning fork again, and you are holding it at the mastoid process. You're asking the patient and instructing them prior to placing it there, I'm going to strike this tuning fork. You're going to hear some sound and vibration, and I want you to tell me when that stops. What you're doing in the process of this test is also counting in your head about how many seconds this is. And when the patient tells you that they no longer hear it, you're not going to strike that fork again. You're now going to bring it in front of the ear canal, which you can see on the right-hand side. And this is going to test air conduction as opposed to bone conduction. So air conduction should be longer than bone conduction in a normal test, which you can see on that left-hand side of your screen. And then inspecting the external ear for discharge and palpating the canal, I have that on the next slide for you. So specifically, what you need to know is about the anatomy when palpating the external ear, knowing where the tragus is. So this little area right here. And some patients will have piercings there, as well as at their helix or their lobule. So palpating the external ear and the tragus, and then the external canal, again, that's going to be just the very opening or the entrance of the canal. When you are using your otoscope, you're primarily looking at the tympanic membrane. So this should appear pearly with no bulging or erythema and not retracted in a normal examination of a patient. I highly recommend that you look at page 415 and table 13.3 in your Bates book. You're also going to be looking at the cone of light, and that's going to be different for each ear. Again, while you're going to be verbalizing, looking in each ear. Also, the safety of using your otoscope, that you are not placing this too deeply into the patient's ear, possibly causing them any trauma, a possible tympanic membrane rupture, or discomfort of the exam itself. So in bracing, I like to hold my otoscope really in more of an upside down motion. And so I like to brace my hand up against the patient's jaw so that when I'm looking, I'm directing the cone of light into the ear to be able to see that tympanic membrane. You're going to verbalize those landmarks to us, that you're looking at the umbo and the stapes. That instrument safety, again, as I mentioned, bracing. And so there are many different videos on YouTube that you can look at on safety of using the otoscope, as well as when you attend immersion and get an instruction about that. So you'll see on the lower portion of your screen some different areas, as well as anatomy of the ear with the incus, the umbo, the cone of light, and the malleus. And then this should look very familiar. So these are the key components of the mouth and pharynx examination. And this comes directly from your Bates book. So when we are finding the areas of the rubric that we're evaluating, this directly translates to your Bates, which is why we always tell you that's the most accurate resource for you to look at. So we're going to spend the next few moments going over the lips, oral mucosa, gingiva, teeth, roof of the mouth, tongue, as well as the back of the mouth. So when you're inspecting the lips, you're looking to see, are they dry? Are they cracked? Are they pink? Are they moist? When you're inspecting the buccal mucosa, you can see this again on the lower part of your screen here in the middle, that you're looking to see if there's any ulcerations. Inspecting the salivary ducts. You're going to inspect the gingiva, looking for pigmentation, any signs of hypertrophy or infection. Inspecting the teeth, so you're looking at the dentition for any evidence of missing teeth, obvious dental caries, or abscesses. And so you can see depictions of adult teeth versus children in terms of the amount of teeth and what they will look like. And so in looking at the anatomy of the teeth, it's very good to start using these anatomical terminology, especially when you are sending a consultation for a patient. So oftentimes you can just do a quick search on whatever search engine you'd like, and that will give you the dentition number or the tooth number. But also utilized are these names like a medial or a central incisor, these lateral incisors, canines, first premolar, second. And then you'll see the different development in terms of when teeth will form for the first molar, second molar, and third molar. And then on your right side here, I just have a quick little diagram to show you really what comprises the tooth: the crown, the neck, the root, dentin, enamel, gums, pulp cavity, and all of those things. So those are not specific to items that you absolutely have to know for this video, but it's a really good review of understanding all of the aspects of the teeth outside of what we can see. When it comes to assessing the mouth, throat, and face, you're inspecting the tongue. So specifically with the tongue, you're verbalizing the visualization of the papilla and the size of the tongue. Does it seem large? Does it seem abnormally small? Inspecting the tongue for strength and for deviation, and that's going to be cranial nerve number 12 or your hypoglossal nerve. Inspecting the soft palate and the uvula. Those are cranial nerves 9 and 10. So your glossopharyngeal and your vagus, and your visualization of that by the patient swallowing. So you're going to say, I need you to swallow for me, and you're going to visualize those areas kind of going up and down, as well as the uvula when having the patient stick out their tongue. Inspecting the posterior pharynx and the tonsils is also very important. That's demonstrated in figure 14.7 on page 421. So verbalizing tonsils by size and grading. So if a patient has had their tonsils removed, again, they're surgically absent. There's nothing to visualize there outside of the posterior oropharynx. However, if a patient has had surgical tonsillectomy and adenoidectomy, they cannot have clinical findings of tonsillitis unless their tonsils screw back, which strangely enough can happen in very rare cases. However, you want to make sure that the anatomy that you are assessing matches the patient, okay, in terms of their history. So some good visualizations there for you. And then what to assess when it comes to the range of motion of the neck. So although this is in chapter 11, this is towards the end of your rubric as we're kind of working in that head to toe fashion. So asking the patient, you're going to have them watch you perform this skill and then return demonstration. During that time, you are going to verbalize the motion that is being performed. So flexion and extension, lateral movement, as well as rotation. And then shoulder shrug is going to be that trapezius muscle group. So that's where the patient is shrugging their shoulders against resistance. And then turning the head against resistance is testing the sternocleidomastoid group. Those are cranial nerves 11, or the spinal accessory nerve. You can see a really good part of your Bates book in box 2314, although that's in a future chapter. I think that this is a great table to discuss the range of motion of that cervical spine and how to instruct the patient to perform that. So I highly recommend that you look at those. When it also comes to assessing the neck, we're talking about lymph nodes, and these are going to be one of the primary areas of lymph nodes in the body. So you do need to verbalize and assess the correct anatomical location to get these points. And you can see I have page numbers for reference here for you, as well as a really great visual on your screen. So your preauricular are in front of your ear, whereas your posterior auricular are behind the ear. Your occipital is in the base, or the posterior aspect of your scalp. You have your anterior cervical, which travels in somewhat of a triangle line in your posterior cervical towards the back. Your submental right under your chin, your submandibular, and your tonsillar nodes, as some feel for, and then your supraclavicular feeling at the clavicle. So those are all of the assessments that we are looking at when we are talking about the lymph nodes of the neck. When you are documenting the assessment of these, they should not be palpable unless there is an infection or a reason for them to be. But you do want to specify any time that you are charting lymphatic in documentation, what lymph node you were attempting to palpate and if it was present or not. So you could say non-tender over the preauricular, posterior, or non-palpable lymph nodes over the preauricular, posterior auricular, so on and so forth for this, in order to make sure that you're documenting it the most accurate way. Then in terms of assessment of the neck, the last area is palpating for that trachea placement. And so how you are feeling for that, and a really good anatomy review there. With the thyroid gland, this is the last part of your rubric, and you are inspecting at a tangential view. So you're basically looking to see if there's any deformity of the thyroid. Inspecting for swallowing. So again, you had the patient swallow when you were testing at cranial nerves 9 and 10. You are also having them swallow as part of the thyroid. Visualization of the thyroid upon swallowing before palpating. Locating the landmarks for palpation, so that cricoid cartilage, figure 11.15, and then palpating the gland on swallowing. So standing behind the patient is the most accurate way to do so, so you're able to really feel those structures better. You can see what a normal thyroid would look like as opposed to a patient who potentially has hyperthyroidism or hypothyroidism and thyroid cancer. On the next slide here, I just have some differences in terms of hypothyroidism versus hyperthyroidism and symptoms and signs that you might expect. And this is, again, directly from your Bates textbook. And then we're talking about our documentation now. So once you have completed your video, Your video should be based on absolutely normal findings. So it should not be based on a chief complaint that you're going to do your documentation portion on, but it should be normal findings only. So when you're submitting documentation, especially with SOAP notes, you need to make sure you're using your APA format, which includes a title page, headers, medical terminology, in-text citations when they're appropriate, and your reference page. So you can see how you're earning full points there. And then choosing a chief complaint. So specifically with this, your week 4 SOAP note, and again in your week 6, when we do neuro, you are going to be selecting a chief complaint to use for your note. So you can choose anything that falls within the HEENT realm. However, you want to make sure when you are deciding that chief complaint, you are using quotation marks, because this should be what a patient would tell you that they are seeking care for. So your video will be demonstrating a normal exam, as I mentioned, whereas your documentation is going to show you are able to practically apply that knowledge. And every SOAP note that you're doing in this course is going to be body system focused. So in choosing that chief complaint, as I mentioned, it's not going to be comprehensive. For example, if choosing the chief complaint of a patient that says, I'm here for a bloody nose this morning, but that's now resolved. You want to think about what are things that are important for that chief complaint. So you're going to use your HPI, your old CARDS acronym, right? Your onset, location, duration, aggravating factors, alleviating factors, timing, severity. You need to know if the patient's ever had this before, what they did to resolve it. A lot of times patients are going to stick something in their nose, or they're going to hold their nose down here. What you will definitely learn in your NP clinical practice is that holding the nose at the base of the nose is not going to change a nosebleed at all, whereas they have to apply pressure at that Kieselbach plexus. And so you don't want the patient to, again, tip their nose back. You want to make sure that they're definitely having their nose towards the ground so they're not swallowing all this blood. This is just an example, but again, clinical pearls to help you. And I didn't think that many people would probably choose epistaxis. So go ahead and write that one off and choose a different chief complaint. In terms of what else do we need to know about a patient who's coming in for epistaxis or a bloody nose? Personal history, as I mentioned. Was this due to an injury or any recent surgeries? Are they using a new medication, which this could be a potential cause? Definitely blood thinners we need to think about. Patients on preventative baby aspirin or other supplements. So this is when those over-the-counter supplements and herbs can certainly cause blood thinning. Did they have any family history of HEENT cancers or nasal polyps? Was there any drug use of snorting or inhalation? Sexual history, probably not pertinent for this. So these are those areas when you are going to start to develop a very pertinent examination, and your SOAP note is going to be based on that chief complaint. So if it's not pertinent, you can, for practice measures, you can write it out and write not pertinent, or you can omit that section altogether if it is not based on the chief complaint the patient is presenting for. Documenting those findings, you're earning full points when you are having your HPI and review of systems pertinent to the complaint, your past medical history, again, pertinent to the complaint. The information was clear and concise and not superfluous, meaning you're not giving us lots of information we do not need. So what do we expect based on any chief complaint for your SOAP note that you are doing for HEENT? And that is that you have a detailed examination for your head, your eyes, your ears, nose, mouth, throat, neck, and lymph nodes. Other areas which can be helpful and very basic in terms of the examination and documentation you're going to perform. Constitutional, what's the patient look like? Are they in any distress? Do they appear disheveled? With cardiovascular, that they have a regular rate and rhythm. If they're tachycardic, that would be a concern. If they're bradycardic, that would be a concern. Pulmonary, that they've got clear lung sounds to auscultation, that there's no evidence of distress, they're not tachypnic. Those are just all good ideas there. Skin, that's certainly something that I would consider documenting, especially for an HEENT complaint, that there's no rashes, that you're not seeing any pallor of the skin, any cyanosis, etc. And then a basic neuro examination, that they appear alert and oriented, and all of those things that you're thinking about with your neuro exam. You're earning full points for writing vital signs, hypothetical vital signs for your patient, making sure that those do match your documentation. And your physical exam findings are organized, thorough, and succinct summary. The physical exam for the particular week's body system was elaborated upon, as I just mentioned. So in Bates on page 379, this is often found in several of your HEENT chapters, but these are some examples of what you might see in terms of clinical documentation. So again, this is not a comprehensive documentation. This specifically came from the eyes when we're talking about how to document findings with the eyes. But you want to make sure that you are using appropriate headers for HEENT in terms of your examination documentation. So while this is a good reference and this is what you may see in clinical practice, we want you to be thorough and really use your rubric, as well as what are those findings that you're expecting based on the chief complaint you chose. If you chose otitis externa, you should have documentation of the ears to match that. If you chose an oral ulceration or a tongue issue, you need to make sure that all of your documentation in your objective assessment matches. Tonsillitis, pharyngitis, a possible thyroid nodule. So any of those things, please make sure that you are looking at what to expect with those examinations and documenting them as appropriate. So now we are on to the assessment and plan section, where you are looking at your differential diagnosis of your chief complaint. So listing at least 3 potential differential diagnoses that could be based on what you found out about this hypothetical patient that you've drafted, right? So when you see a patient with otitis externa in clinic, they may have very different symptoms, but for your old cards in your HPI, you're going to be thinking about those typical symptoms. So that's going to require some research on your part just to be forefront about that. You're going to use in-text citations as pertinent for the clinical practice guidelines and evidence-based support. So how did you come to the conclusion of these 3 diagnoses being potential for this patient? So you're going to tell us in your documentation how you came to that, and then your final diagnosis that you've selected. And oftentimes you've already thought about what final diagnosis you're probably going to use based on the chief complaint that you selected. And then your plan on the final diagnosis. So that should include a diagnostic plan. Are you needing to order any tests to be able to come to this? And you may not need any tests. You may not need point of care. It may be on examination alone. You may not need labs. Treatment plan. So you always want to consider that if the patient is coming to you, they may be in pain. And so supportive measures, even over-the-counter symptomatic management, that can be something such as heat and ice. It can be positioning. It does not always have to be Tylenol or acetaminophen. It does not have to be ibuprofen, Motrin, Advil, or naproxen or Aleve. So if the patient is adverse or does not want to use medical management, they can have supportive comfort measures, but you need to make sure you're documenting that as such. If you do decide that based on the diagnosis you've chosen, there's a medication that's needing to be prescribed, we need to know everything about that medication, just as if you were sending that prescription to the pharmacy. So we need to know the name. Please try and use the generic, as many insurance companies do not cover brand name medications, especially Medicaid and Medicare services. We need to know the dose, the route, how often the patient should be taking that medication, and the reason. So additionally, if it was a pediatric patient and you were writing a suspension, you would make sure that you're including how many mLs need to be prescribed, just as you would for how many tablets. A referral plan. Again, that is as pertinent. Education to the patient. So you always want to be sure that you are documenting your education. This is really something that nurse practitioners take a lot of pride in, our education to our patients on the process, why we believe this to be the case, what they can do for themselves at home, when to return to the clinic, and the care that they might need, as well as escalation or a follow-up plan. You'll earn full points on that if you have performed those correctly, as you can see on your right-hand side. And then, as I mentioned, there is no Dropbox for week 4, and so no summary to complete. This is just a supplemental video to really help guide your practice this week. So I hope that you have enjoyed this content, and I wish you all the best as you are working through week 4.